Hi, everyone. My name is Nick Shammas. I'm an interventional cardiologist and the founder and the research director of the Midwest Cardiovascular Research Foundation. I will be presenting to you the intravascular lithotripsy treatment of severely calcified common femoral arteries. And these are results from the DISRUPT-PAD3 observational study that I was one of the investigators involved in this particular registry. So if these are first of all my disclosures. So we know that the common femoral artery treatment can be performed by endarterectomy or by endovascular interventions, both of which have limitations. Many patients can be not surgical candidates, and endarterectomy is associated with morbidity and mortality. Endovascular interventions are associated with complications in calcified common femoral artery lesions, and particularly side branch embolization and loss of those side branches. Intravascular lithotripsy has shown promising safety and effectiveness in the calcified common femoral artery lesions. However, the series were small and real-world evidence from a large cohort is lacking. So we know that intravascular lithotripsy generate sonic pressure waves using lithotripsy. It delivers 1 pulse per second at effective pressure of 50 atmospheres. That leads to fracture of both the superficial and the deep calcium and allow low balloon pressure inflation, which avoid barotrauma to the vessel wall and hopefully severe dissections and stenting. So the DISRUPT-PAD3 observational study is a prospective, multi-center, single-blind observational study with the planned enrollment of 1,500 patients to assess real-world peri-procedural outcomes of IVL for treatment of calcified stenotic peripheral arteries. This interim analysis focused on the treatment of calcified common femoral arteries that involved the heavily de novo CFA lesions that were treated with the IVL plus or minus adjunctive therapy from December 2017 to 2020 in March. There was 109 patients and 109 CFA lesions included at 20 sites. And the objective of this interim analysis is to assess the real-world peri-procedural outcomes of calcified common femoral artery lesions following the IVL treatment. So these are the baseline characteristics. The mean age was about 72 years, and it's not surprising to see a significant number of hypertensive patients and patients with hyperlipidemia. About a third of the patients were diabetic, and renal insufficiency was present in 18% of the patients, and patients on dialysis were about 5.5%. Notably, 30% of the patients had critical limb ischemia, mostly Rutherford 4 and 5. If you look at the reference vessel diameter, this is core lab adjudicated, was 6.3 millimeter, with a diameter stenosis of 78%. About 1 in 5 lesions were CTO, and the lesion length was 5.6 centimeter, and severe calcium using the Park definition was 79% of cases. Eccentric disease was present in 38% also of lesions. So this is an example, of a common femoral artery treated by the IVL. On the left side, you can see where the arrows are pointing, very severe calcified and severely diseased common femoral artery with the diameter stenosis. It was 89.6% and the reference diameter of 6.6 millimeter. Using a 7.0 IVL and 90 pulses, you can see the acute gain now was 3.9 millimeter and the diameter stenosis was down to 30.7%. And at the final post-adjunctive treatment, you can see that the acute gain now is 5 millimeter with the diameter stenosis of 14.6%. Very nice results. Now, if you look at the procedural characteristics, it's not surprising. The procedure time, contrast volume, and fluoroscopy time really have not changed much. These are the numbers that we normally expect in our procedures. Embolic protection was used very infrequently, in fact, only in 11.9% of cases. And the number of IVL catheters required was on average 1. Pulses used were 167 pulses on average. And more important, the standalone IVL therapy was in 66% of cases, And in about 33.9% of cases, we had adjunctive calcium modifying therapy added to the IVL. And that included specialty balloon, in about 13% of cases, and atherectomy in about 23% of cases. Notably, patients were treated with a more definitive therapy at the end in about 70% of cases with drug-coated balloon and about 15% of cases with stenting. So if you look at the angiographic outcome, and this is again core lab adjudicated, the diameter stenosis was reduced pre-procedure from 78% to 30% post-IVL to a final diameter stenosis of 25%. And that nicely correlated with the minimal luminal diameter gain of 1.4 millimeter pre-procedure to 4.5 millimeter post-IVL and 4.8 millimeter at the final treatment. Again, very nice profile when it looks at complications, no flow limiting dissections, no perforations, no distal embolization, no slow flow or no reflow seen, and no abrupt closure seen. And these were all core lab adjudicated. So to conclude, this interim analysis from the real-world Disrupt PAD-3 observational study represents the largest cohort for IVL treatment of heavily calcified common femoral artery. The outcome were very positive, showing significant improvement in diameter stenosis and MLD immediately following the IVL treatment, with no serious angiographic complications seen. And this is all core lab adjudicated. The treatment approach was per operator's discretion in this real-world study. And if you look at the IVL use alone as a calcium modifying therapy, that happened in 66% of cases. Again, all these cases were performed in the US, and data may be reflective of the US current practice. So future studies with longer term follow-up, of course, are needed to understand that durability of the IVL treatment in the calcified common femoral arteries. The common femoral artery vessels, if you look at them, these are very large vessels. They are really rarely, less than 7 millimeter by IVUS. In fact, they are quite large. And they usually have a very heavy plaque burden. And that heavy plaque burden, is not just calcification in the superficial layer, but also calcification in the deeper layer of the plaque. So using the IVL is exceptionally suited to create more of these fissures and cracks in those deeper layers to change the vessel compliance quite effectively. Using atherectomy alone many times is not capable of reaching those deeper layers. So with the use of the IVL, now you're tackling both the superficial and the deeper layer, allowing, the expansion of that vessel, the gain in the minimal luminal, area post-treatment, hopefully with the lowest pressure possible, the lowest potential barotrauma dissections and stenting. Our practice almost mirror image, the findings, what we see mirror image, what we have seen with the PAD-3 observational study. And in fact, the use of embolic filter protection has been virtually nothing when we use, the IVL system. And our distal embolization virtually non-existent. So that is very much what we have seen in the observational study. The rate of dissection has been very low, and so the bailout stenting was very low. And we find out that many times, similar to the PAD-3 OS study, every now and then, we resort to a combined therapy, sometimes of atherectomy followed by the shockwave, to tackle more effectively these very heavy, bulky lesions. And again, that's pretty much what operators have done in the PAD-3, observational study with very good results. So there is some merit sometimes to the dual, therapy and the dual approach. But the point is quite simple. What we have seen exactly is what the study has reported, and kind of almost a mirror image. In general, you probably will get away with the IVL therapy alone most of the time. There are some lesions which are very bulky, very heavy, like CTO in a common femoral artery has enormous amount of plaque in it. and it may be helpful to debulk some of that plaque prior to use of the IVL system. If you have calcified disease, which you can see they are very extensive calcification, going across the lesion as well as involving the vessel walls in a bilateral fashion, or if you're using IVUS, in almost an over 270 degree arc, then you're dealing with very, very heavy calcium. If you can debulk some of that sometimes prior to the use of the IVL, I find it very helpful in a sense, gaining more MLA that way. Again, we don't have comparative data, of course, with the combination therapy versus IVL alone. It would be very nice to have that data. But at this point, I find very bulky, very calcified lesions, maybe a dual approach is a suitable approach.